Thank you, Hetty, for bringing along with Darcy into the room survivors, both from the patient perspective and the caregiver perspective. It allows us to have a face and experience as we now talk about the science, which of course is talking about human lives. As Niraj reminded us at the very beginning, it starts with people. So our next speaker is going to be Dr. Barbara Andersen from Ohio State, and she's going to be talking about the psychosocial challenges when we think about survivors of adult cancer.
Thank you, Julia. It's indeed an honor to be here. The eloquence of our last two speakers and many of those before are breathtaking. So when I got the title to what I was supposed to talk about, the title that you're reading is a lot longer than the one up here, because I was a bit intimidated about that title. And so I thought, well, it kind of feels like I'm supposed to talk about all of the above. And thankfully, I looked at the program, and 3 of the topics got mixed because we heard about them this morning. The next 2, however, have not been on the program. We've heard some allusions to sexuality outcomes and fertility, which indeed are concerns of cancer survivors, and we can talk about that individually, but I'm not going to focus on that this morning or this afternoon, and instead zoom in on stress and significant symptoms of anxiety and depression. So my agenda is to just kind of overview those psychological responses and just describe them in terms of their impact on cancer patients. Focus, then shift to psychological treatments for managing psychological symptoms, and then talk about moving forward. And so why stress, depression, and anxiety? Countless references to those problems this morning because they're common, terribly common. But we do know risk factors for them, obvious risk factors that we can do something about. They are responses that drive other outcomes, other psychological responses, important behaviors and biology, and actually disease endpoints, and in some circumstances they can be deadly. Sometimes it helps to have kind of a conceptual framework to understand responses like this, and this has been one that we have used over the years because indeed cancer diagnosis is the period of the most difficult distress, bar none. And so how relevant is it that we are talking about kind of pre-rehabilitation services? But it drives other important behaviors, the health behaviors. To the extent that we're stressed, we drop out our positive behaviors. We don't run, our sleep falls to pieces. We have higher rates of negative health behaviors in terms of poor diet and so on. So they really play an important role in moving the system forward. So let's talk about comorbid psychopathology, and in this case I'm talking about diagnosis of anxiety or depressive disorders. The estimated incidence of cancer patients at the time of diagnosis that also have comorbid psychopathology runs up to about 20%, with another 10 to 12% with anxiety disorders. Of those cancer patients that have significant symptoms at the time of diagnosis, at least half of those people will have had a prior history of troubles with coping with recurrent major depressive disorder or anxiety disorders. It's also the case that half of them with depression will also have comorbid anxiety. And so it's a difficult, complex picture. If you look at point prevalence, so these are studies when patient population-based studies finding out, is the person I'm interviewing today depressed? So it's point prevalence at that point in time. You can see how much higher the incidence is of major depression compared to the general population, with other kind of sub-diagnoses such as dysthymia also at a higher incidence. The same is the case for anxiety disorders. And so who's at risk? And I really do want to emphasize this part, because these are clear characteristics that are knowable and easily knowable at the time of diagnosis or thereafter. So who's at risk? As I mentioned, those with a prior history of anxiety disorders, plus or minus substance use. And in addition, men are more at risk. Those aged, be that over 55, 65, pick a decade, it just goes up with the decades. Those who are alone, either actually or functionally, many people have partners, but that relationship may not be supportive or helpful, and may also be problematic in terms of the individual's health. Those individuals that are unemployed, low SES, patients that are going to be receiving the most toxic of therapies, and those individuals with progressive disease or recurrence. So these are clear, knowable pieces of information that we can know at the time of diagnosis. I just want to kind of illustrate this point very kind of with a couple of examples. This is data from literally the population-based, almost 1 million people in these figures. The first two figures are 5-year survival. The next two are 10-year survival. But it's a very simple figure. Look at the individuals that are married. So in every category, 5 years, 10 years, the marrieds have higher survival rate than all the other kind of singletons, if you will. And then men having lower survival rates in each figure than do the women. How about another example? Toxic therapies. The Taxanes were introduced several years ago now to improve breast cancer outcomes. Clinical trials showed common difficulties with neuropathies, but what they didn't show were heightened risk for depressive symptoms. This is data from a clinical trial in which roughly half of the patients received taxanes and half did not. And this is the higher incidence of depressive symptoms during the period of therapy. So if you actually look then at how many individuals, aside from having increased symptoms, actually had severe symptoms enough to indicate depression, you can see a difference of about 3% in the non-taxane group and about 18% during the 12 months. And by 12 months, they were off of therapy, well off of therapy. And by 18 months, that difference was still there. So again, just a piece of data that illustrates what kind of risk people can be at. This is a very interesting study that came out about 5 years ago, and it was just studying stress, depressive symptoms, and so on, and might those symptoms produce heightened risk for premature mortality. Whoops, sorry. And what you see here, so these are hazard ratios. So any figure, any number over 100 would be a heightened risk for premature mortality. And so for the overall analysis, where you're looking at stress, depression, and so on, is there a heightened risk for premature mortality? And yes, it's 1.29, and you can see the number over here, and then kind of breaking it down into depression, for example, a hazard ratio of 1.34. So when I make the comment about these problems being deadly, I'm not being flippant. And this is data literally from hundreds of thousands of patients. And certainly the most difficult circumstance of these difficulties remaining untreated are those individuals that have severe depression, so severe that they consider suicide. So who's at risk for our patients? Well, nobody should be at risk is certainly the bottom line. But if we're not offering treatment, who are the most vulnerable? So again, you can see all cancer patients are at risk versus the general population. And again, this is an example of just among kind of 50-year-olds. You can see the heightened, these are standard mortality ratios. And so time since diagnosis, people have mentioned over and over again how important that early intervention. Well, this is data to suggest even more so. And those, again, male, almost double the ratio, standard mortality ratio for women. Those older, and you can see the ratio across the age groups for 50-year-olds, for 60-year-olds, for 70-year-olds. Those alone, this is a refrain, those with distant and progressive disease. And if you look at the individuals with the worst risk, and you find how high the risk is, how high the risk is for lung cancer, well, we've got a perfect storm there. We usually have men, men of in the elderly years, and they most commonly diagnosed as stage 3, stage 4. I'm going to pass it. We had heard a talk this morning about someone saying they knew something was wrong. We actually did a study with women with recurrence and kind of found that phenomenon. But I want to just show you a very, very reliable effect. These are very simple studies. Patients are assessed with a quality of life, some type of measure at the time of diagnosis or initiating treatment. And these are survival curves. So what you see is lower survival for the folks that describe themselves as having poor psychosocial well-being. Well, that's lung cancer. Same effect with stomach cancer. There they're rating social functioning. Physical quality of life. This one's divided by quartiles in terms of their rating of quality of life, and lack of energy and survival in gynecologic cancer. So I hope this can kind of illustrate for you not only how important our screening is, but really how truly, truly, truly valuable patients' self-report of their functioning is. Okay. So let's talk about interventions. So that was kind of the difficult news if we don't do anything. If kind of status quo proceeds. But I think something positive, really positive, is through efforts like Julia Rowland's, is that over the years we actually have done some good work. But it's not a history that's all that long. For example, this is one of the very earliest articles on psychosocial anything and cancer. And in the late 70s, we were hunting around for, what's the factor that is related to cancer incidence? Well, 40 years later, that search has still come up empty-handed. But as what I showed you is that psychological factors do matter in terms of cancer outcome. So fast forward a little bit now. Now we're up to 1992, and there have been all of 19 intervention trials with cancer patients conducted. The folks that I've been talking about this morning here are essentially the high risk. The outcomes were divided in terms of what was the outcome from the study and a risk group. So we can think of, actually in this review, high risk individuals were those with significant symptoms or progressive disease. And you could see that our interventions were very effective. We could produce significant reductions in emotional distress, quality of life, and so on. Well, how did we achieve that? How did we achieve it in 1992? We're essentially achieving it the same way today. The components of effective interventions typically include some sort of stress reduction strategy, be it relaxation training, be it yoga more recently. The interventions provided information about disease and treatment. They offered behavioral and cognitive coping strategies, usually problem solving around common problems such as fatigue, assertive communication with people like healthcare providers, some mechanism for providing social support, and potentially focused interventions. Well, those core components then are pretty much the core components that we're seeing now. However, now we have meta-analyses. So flash forward another 25 years or so, we have enough studies to do meta-analyses on. And so I've summarized about a half a dozen meta-analyses. And you can see that we have moderate to actually very large effect sizes, particularly for depression. I keep doing this. Particularly for depression. Here's an intervention for relaxation, effect size 0.3, psychoed, huge effect size, very large effects, MBSR, CBT, and so on. But what's kind of important to know about these studies is these are studies that essentially took all comers. These weren't studies that screened and then, conducted the intervention with those with anxiety or depression. It basically treated everyone that said, yes, I'll be in your study. And so what you see here is actually an underestimate of the effect sizes that you can get from these interventions. And actually, when you include depressed people in these kinds of interventions, you get great reductions in depression. You can also get biologic changes. And actually, when you look at the biologic changes that you can get from interventions, yes, study arm makes an important effect on producing those positive changes, but it's really the effect of reducing that distress for people. That's what's really driving these kinds of biologic effects. Some interventions have also produced changes in disease endpoints. There's not many examples of this, but it can be done. So as I think about it, I think we built it. I do believe that these 40 years of progress, 300 studies, 40 years, about 9 studies a year. Even with that level of funding, I think we've done a pretty darn good job. We've got treatment strategies that work. We found effects reliably. So where can we go now? I think we're at a bit of a watershed, as we've talked about, pretty much today in terms of on what side of this equation are we going to fall? How can we move forward and swim rather than sink? So what can we first do? As has been mentioned here, and I really did do this talk last night. I didn't just listen this morning and write this down. So clearly, we need to screen for anxiety and depression and implement what we have now in hand. We have guidelines for how to screen. These are ASCO guidelines. And if you think about guidelines, the kind of thing you're going to find is that essentially half of the patients will be individuals that will profit from the psychoeducation. And it's the other 50% that are more active psychosocial programming needs to go. This is a model essentially putting that logic out in terms of screening, identifying who's had moderate symptoms, who has severe symptoms, and then moving essentially with stratified step care for those individuals with the moderate symptoms versus the severe. Expand the dissemination and implementation of what exists now. This is an article that came out a few years ago, and it was actually written by Dr. Netta in Cancer Control, and reported that there hadn't been much work in the area of dissemination and implementation of cancer survivorship programs. Hopefully that will change. If you do it, that is, if you train individuals, if you offer a way for providers to learn empirically based treatments, they will come and then they can go home and they actually will implement things. So if we have vehicles to do this, we can change the needle. In terms of new interventions, stimulate and reinforce innovations. One might be optimizing the interventions that we have now, expanding our outcomes so that they include other outcomes in addition to psychological ones, healthcare outcomes, costs, and probably shift some interventions to e-health. Not necessarily the interventions for everyone, but for some individuals. And really embrace that whole cancer patient. If you think about who's treated at our cancer centers, about 15% of people. Sometimes those cancer patients don't look like the rest of America. So where, let me move forward, what do the cancer patients look like? Well, they have diabetes, they might have substance use problems, they're in the range of poverty, they're uninsured, and probably there'll be more uninsured, the rate we're going now. Half of them are alone, non-Caucasian in a few years. That's the percentage, and the bulk of the studies I showed you were done with Caucasians. I think there was a dozen studies with non-Caucasians. Obesity is the problem, and over 65 years. So this is America. You know, this is America, and this is our cancer patient, and that's how we need to be thinking of our interventions as we move forward. Thank you.